27th, and we're back from break. And we are moving from S28 to S18, which means that I will conflate the two of them for the next month, probably. Too many eights. And our legislative council is going to do a walkthrough of what came from the Senate.
Yes, good morning. Jen Carby from the Office of Legislative Counsel. I'm going to put the language up in just a moment, just to level set where we are process-wise. S18 was voted out of, as amended by Senate Health and Welfare, was voted out of the Senate on third reading yesterday. Today is the reconsideration day. The Senate holds on to bills for an additional day in case a member wants to reconsider. I'm not aware that there's anything planned on this one. But it hasn't been sent over to the House yet, so we do not have an as passed by Senate version yet. I'm going to be showing you the as passed, as recommended by Senate Health and Welfare, which was adopted. So this will be the text will be the same, but it still looks like a Senate Health and Welfare amendment.
Yes.
All right, so we are looking at S18 as recommended by the Committee on Health and Welfare, which was the strike all amendment, so it makes it easy for us to look at. This is an act relating to licensure of freestanding birth centers. And the bill has changed somewhat since introduction. I think sort of the overall concept of creating a licensure process for freestanding birth centers is still the same. And there's still some other provisions that are the same, but some of the way it's framed is a bit different. So it starts out by creating a new chapter in Title 18 on birth center licensing. It is like some of our other facility licensure chapters, modeled to some extent on the hospital and now ambulatory surgical center licensing chapters, although there are some unique provisions specific to birth centers. Starts out with definitions. So important one to start with is the birth center definition. And that is a facility, the primary purposes of which are to provide midwifery care, low-risk deliveries, and newborn care immediately after delivery for a stay of generally less than 24 hours. And importantly, the term does not include a facility that is a hospital, is part of a hospital, or is owned by a hospital. We're not talking about a hospital's birthing center. We're talking about a standalone. We've sort of been referring to as freestanding birth center. It's also does not include a facility that is an ambulatory surgical center, and it does not include the residence of the individual giving birth. So you'll hear more about what these birth centers look like. And my understanding is they're often sort of a home-like setting, but it is not somebody's home. We're not regulating somebody's home, and it is not a hospital or a part of a hospital. But it does specify that a birth center may be located on the grounds of a hospital. And we have definitions of certified nurse midwife, which is a professional license in accordance with the Advanced Practice Registered Nurse subchapter in 26 VSA Chapter 28. It's a type of Advanced Practice Registered Nurse. Change of ownership, which comes up in the bill at one point, means a change in the majority or controlling interest in an established birth center to another person. A corrective action plan is a written strategy for correcting an issue of partial compliance, deficiency, or violation of this chapter or rules adopted pursuant to it. A licensed maternity care provider is a licensed provider whose professional scope of practice, as established under Vermont law, includes preconception, prenatal, labor, birth, and postpartum care and early care of a newborn. And this person may be the primary attendant during the perinatal period. Licensed midwife is a professional license in accordance with another part of Title 26, what people have sometimes referred to as lay midwives. We have a licensure process. It's different because they're different from a certified nurse midwife. Licensed provider is an individual who's licensed or certified in Vermont to provide specific healthcare related services within a scope of practice defined by licensing statutes and rules, and may include certified nurse midwives, licensed midwives, advanced practice registered nurses, physician assistants, naturopathic physicians with a childbirth endorsement in accordance with certain statutory provisions, doctors of nursing practice, and physicians. So licensed provider is potentially a broader term than licensed maternity care provider.
Can you just define, for those of us who may not know, perinatal?
Yes. Perinatal, which you'll get to talk about more in the context of S53, if you take that one up, is really the period, the time period before birth, during birth, and after the birth of a child. So it's pregnancy. So kind of what we're describing here as at least the prenatal, labor, birth, postpartum care, and potentially early newborn care. Peri means around, so it's the period around birth.
Thanks.
Yep. That one I could do. Some of this, right? All right, section 2352 establishes the license and the prohibitions. So no person shall establish, maintain, or operate a birth center in the state without first obtaining a license for the birth center in accordance with this chapter. It allows a birth center to be independently owned and operated by a licensed maternity care provider. This is one of the defined terms. And it prohibits anyone from representing themselves as a birth center or using the term birth center in their title or advertising, publications, or other form of communication unless they've been licensed as a birth center in accordance with this chapter. And a license is not transferable or assignable and is issued only for the premises and persons named in the application. Section 2353 requires an application for licensure of birth center to be made to the Department of Health in a manner specified by the department and to include all information required by the department. Each application for an initial license, renewal of a license, or a change of ownership must be accompanied by a $250 fee, and fees collected under this section will go into the hospital licensing fees special fund. That's where the Department of Health's licensing fees all go, and they use them to offset the costs of licensing birth centers and other facilities that they license. Let's see, confusion.
Well, is that just the name? I'm assuming that's just the name of the special.
It is the name of the special fund. Yes, they do not create a special fund for each type of facility they license. They all go. I think it was originally created when the type of facility that the Department of Health licensed was a hospital. It still retains the name Hospital Licensing Fees Special Fund, but it holds funds for several different license types that they regulate.
But the fees will only be used for this particular.
You'd have to ask the department. I mean, I don't think, funds are fungible. I think they do a lot of inspections and other work as part of their licensure of different facilities. I don't know how they expend monies from the fund, but this is my understanding is a sufficient fee amount to allow them to do the work.
Not to interrupt, but I want to let the committee members know that there is a fiscal note on this that we got, and it's posted on our website. So
yes, and this would need to go to Ways and Means because it has a fee in it. But the funds are available to the department to offset the costs of licensing birth centers. So I don't know that there's a one-to-one correlation. They could talk about how this fits with the rest of their work. License requirements 2354. Upon receipt of an application for a license and a licensing fee, directs the Department of Health to issue a license if it determines after an inspection conducted by the department or its designee, who in this case is often the Department of Disabilities, Aging and Independent Living, that the applicant is able to operate a birth center in accordance with rules adopted by the department. And you'll see there's some pretty extensive rulemaking provisions toward the end of the chapter. Revocation, this is the process, again, pretty standard to our licensing statutes about what would cause a revocation of a license. So and what the process looks like. So this has the Department of Health, after notice and opportunity for hearing to the applicant or licensee, authorizes them to condition, deny, suspend, or revoke a license in any case in which the department finds there has been a substantial failure to comply with the requirements established under this chapter. It talks about how the notice would be served by registered mail or personal service, set forth the reasons for the proposed action, and set a date not less than 60 days from the date of the mailing or service on which the applicant or licensee will be given an opportunity for a hearing. And after hearing or upon default of the applicant or licensee, the department will file its findings of fact and conclusions of law. A copy of the findings and decision will be sent by registered mail or served personally upon the applicant or licensee. And the procedure governing hearings authorized by this section will be set forth in the rules adopted by the department and not subject to the contested case provisions of the Administrative Procedures Act. Section 2356 has the appeal provisions. Any applicant or licensee or the state acting through the Attorney General who is aggrieved by a decision of the Department of Health after a hearing can appeal the decision in accordance with some of the standard Department of Health appeals processes set forth in 18 VSA Section 128. So that references to, and pursuant to Section 129, an appeal under this section will not stay the effectiveness of an order entered in accordance with Section 2355, that previous section. But any party can seek a stay order in a superior court where the appeal is being heard. So this is some fairly technical procedural stuff to make sure that if there is a potential for a condition or revocation of a license, there is due process afforded. Section 2357 requires the Department of Health or its designee to make or cause to be made such inspections and investigations as the department or designee deems necessary. It specifies that a birth center, including its buildings and grounds, and in accordance with applicable law, its records must be subject to inspection by the department and its designee at all times. If a birth center is found to be out of compliance with any requirement of this chapter or the rules adopted, the department may, again, condition, deny, suspend, revoke, or refuse to renew the birth center's license or ask the birth center to develop and implement a corrective action plan. And if the department finds a violation as the result of an inspection or investigation, the department must post a report on its website summarizing the violation and any corrective action required. As far as records, Section 2358 provides that information received by the Department of Health through filed reports, inspections, or is otherwise authorized by law shall, and here's some privacy provisions, not be disclosed publicly in a manner that identifies or may lead to the identification of one or more individuals or birth centers, shall be exempt from public inspection and copying under the Public Records Act, and shall be kept confidential except as it relates to a proceeding regarding licensure of a birth center. And then it just specifies that summary summary reports of violations do not get caught up in that confidentiality piece. They would still be posted on the website. Here's the rule-making provision. Requires the Department of Health to adopt rules, in this case in accordance with the Administrative Procedures Act, as needed to carry out the purposes of this chapter. The rules must be based on the National Birth Center Standards published by the American Association of Birth Centers and must, at a minimum, include several provisions regarding requirements for operating a birth center, including requirements for safety, sanitation, and health, provisions regarding obtaining, storing, and dispensing pharmaceuticals consistent with state and federal laws, requirements for notice to the Department of Health when there's a change in ownership of a birth center and any additional licensing requirements related to a change in ownership, provisions regarding the scope of services that may be provided at a birth center, including risk factors that would preclude a patient from receiving labor and delivery services at a birth center, provisions regarding appropriate staffing for a birth center, including the types of licensed providers who may practice there, provisions regarding birth center complaint processes, provisions regarding, yes.
Oh, yes, Mark.
You can finish that list in a minute.
Okay. Provisions regarding birth center facility, equipment, and supply requirements, including requirements for maintenance of safety, sanitation, and health. Provisions regarding record retention and confidentiality, quality assurance and improvement, processes for development, submission, approval, and implementation of corrective action plans, and a requirement for written practice guidelines and policies that include procedures for transferring a patient to a hospital if circumstances warrant.
Was there discussions? I'm thinking about the inspections language and that the department can perform inspections, including I think it said record keeping.
Yes, to the extent permitted by law, state and federal law. Yep.
So one of my concerns is that the person doing the inspections is someone who knows standards of practice well, both of documentation and so it's someone who understands perinatal care and documentation. And was there discussion about making sure that the person doing the inspection knows the field well when they were talking about rulemaking and?
There was not discussion specifically about that, but I think it's something you may want to ask the Department of Health
Okay,
when they testify on the bill. I believe they have fairly standard practices for how they inspect other facilities, or really it's Dale that I believe does the Department of Disabilities, Aging and Independent Living Survey and Certification Unit that does the inspections. But I would defer to their understanding and how they determine who does the inspection and what the qualifications are.
okay, thanks.
Can you flag that question?
Yeah.
I've taken a note of it right
Oh,
now. too.
okay.
Thank you.
And then finally, for this part, section 2360 is specifies that nothing in this chapter or rules adopted pursuant to it shall be construed to expand or limit the scope of the services that a licensed midwife, certified nurse midwife, or other provider may offer at a birth center or perform in a space that is shared with or adjacent to a birth center. And it goes on to say that a birth center may serve as a location for additional services offered in shared or adjacent spaces, including outpatient gynecologic care, primary care, and education and support services, provided that any licensed provider providing services in those spaces shall only provide services within their authorized scope of practice. Section 2 then moves into an existing provision of law. This is on health insurance, and this is adding to an existing provision that requires health insurance plans to cover services provided by a licensed midwife or certified nurse midwife for services within their scope of practice. And under current law, that's provided in a hospital or other healthcare facility or at home. This would specifically add birth center and also specifically require coverage of prenatal, maternity, postpartum, and newborn services provided at a birth center, including birth center facility fees. Section 3 is now looking at the certificate of need statutes. So this committee is familiar with those. This would add
Back to them.
new exclusion, adding to the existing exclusion in 18 VSA 9435A for offices of physicians, dentists, and others, adding that the exclusion provisions of this subsection shall also apply to birth centers licensed under Chapter 53 of this title. So that was the new chapter. I will pause here just to say I was asked yesterday in Senate Health and Welfare, we're walking through your CON bill, about whether we needed to add a provision in an earlier section on transfer of ownership and specifically carve out birth centers. And during that testimony, I pulled up this language. And I think because the exclusion is from the entire subchapter on certificate of need, we don't need to put a provision, a carve out elsewhere in the same subchapter, because then that creates confusion about whether we didn't specify other entities that are carved out of the whole subchapter from transfer of ownership, things like that. So I think this provision is sufficient because it excludes at the beginning of the subsection from the entire subchapter. And then the exclusion provisions of the exclusion from the subchapter would also be applying to birth centers. But I just wanted to flag that because I talked about it down there and said I would talk about it here.
So just so I'm clear, if we kept this language that the Senate has brought to us, we would be adding birth centers as an exemption from the CON process,
Yes.
regardless of any of the financial thresholds.
That's right.
We previously said.
That's
So
right.
if somebody wanted to build a $10 million birth center
Let's say $11 million just to.
and $1 birth center, then they would not be subject to CON.
With this provision, that's correct.
Okay. Right. That's a really nice. birth
Really fancy.
So that's something for this committee to consider. And, it may depend for your purposes on where things seem to be going with H96. I'm getting all of those confused. H96 in the Senate.
Join the club.
Excuse me, section 4 directs the Agency of Human Services to seek approval from the Centers for Medicare and Medicaid Services to allow Vermont Medicaid to cover prenatal, maternity, postpartum, and newborn services provided at a licensed birth center. I believe they're currently excluded in our state plan. So it would really be a state plan amendment, I believe. And to allow Vermont Medicaid to reimburse separately for birth center services, including birth center facility fees and for professional services. Finally, section 5 is the effective dates. Section 1 on licensing, birth center licensing would take effect on January 1st, 2027, or the effective date of the birth center rules adopted by the Department of Health, whichever comes first. So if the department got its rules in place earlier than that, then the licensure could occur earlier than that. Section 2, health insurance coverage takes effect on January 1st, 2027. Section 3 takes effect on, Section 3, the exclusion from CON laws takes effect on July 1st of 2025. And then section 4, the request for federal approval takes effect on passage and directs the Agency of Human Services to submit its request for approval of Medicaid coverage to CMS by July 1st of this year, with Medicaid coverage beginning on the later of the date of approval or the effective date of the birth center rules adopted by the Department of Health. This effective date section would take effect on passage.
You see me deep in, I was thinking about. So we have no effect on in the page 7, end of the page 8. The no effect on scope of services. Little b. That they could be located in places offering adjacent to outpatient gynecological care, primary care, education support. And I was just thinking around pediatric. I'm sorry, I'm like, because it covers that AHS, talking about Medicaid coverage of prenatal, maternity, postpartum, and newborn services. Newborn services are usually provided, and I'm thinking of it in a hospital setting. Granted, I realize that a certified nurse midwife, they assess the newborn. But shouldn't we have some sort of something in here regarding pediatric care? Because in a hospital setting, it's usually a pediatrician that provides the newborn services.
I would refer to
Maybe
it.
maybe we'll wait until we get there. I'm possibly overthinking things. Daisy?
Do we define freestanding anywhere or
We
freestanding?
don't actually use the term. It's used in the title of the bill, but it's not actually used in the bill itself. It's really just the definition of birth center, which is describing it as being not part of a hospital.
Because I thought that little b, which is explaining adjacent and kind of locational stuff, that might help with that, because I feel like I'm also a little, I guess you're talking more about services. I'm thinking more geographic location.
Yeah, I'm thinking about who would be practicing here. And there's nothing that precludes, say, an obstetrician from practicing.
No, and physician is one of the licensed maternity care providers.
And that would cover a pediatrician also. So a pediatrician could come in and assess the newborn and if called upon to do so.
Yeah, yes. I
Because-
don't think there's anything in here. It's really talking more, I think B is really, my understanding of it is that there may be in shared and adjacent spaces. So in the same building, there may also be, that may be where the doulas work out of. It may be where providers offering outpatient gynecologic care, or primary care, which could be pediatrics. But it could also be, there could be, I don't know what prenatal yoga offered there. I mean, I think the idea is that there could be a whole suite of services that are available, and there was interest in making sure that there was nothing that was precluding that. So being clear that was permissible.
So that language does allow for prenatal yoga, birthing classes and things like that.
Yes, yes, birthing classes is a great example too. Yes, I think, and then it's the provided part is just if it's a licensed provider who's providing services, they're not, you can't say, I get to provide outside my scope of practice because I'm here at a birth center. It's still limited to whatever their authorized scope of practice is under their license or certification. But it's just allowing for co-use of space. That's my understanding of the intent there.
Now I'm thinking of all the things.
Right.
Classes, lactation consultant.
Exactly, lactation consultant, another great example.
Mari.
Going back to page 4, line 14. Can you go into more detail about what contested case provisions are?
I may want to defer, I don't know if OPR, who happens to be in the room, can speak to contested case. It's a particular set of requirements for a process under the Administrative Procedures Act. And this is basically saying the process will be spelled out there and not in, it will be spelled out in the rules and not go through the contested case process. And I don't know how they relate to each other. So I think it's really a question for the health department. I'm just looking at OPR because Jen's in there.
Okay. All right, thank you.
Daisy, did you have something else to?
And this was language proposed by the health department. I will say this particular piece.
And everything in here is consistent with other facilities that the health department licenses, or it's.
I would say it's not inconsistent. It is different because the birth center is different than a hospital.
Okay.
And I think some of the provisions in here have been updated to reflect more sort of current practice in the health department or how they do licensure. Some of the language and references to processes in the hospital licensing statutes in particular are a bit antiquated.
Yes, I was thinking more, are we missing anything? We're not missing anything.
I don't believe so. And I know that, I mean, this version of the language was kind of the consensus agreement from the stakeholders and from the advocates for center licensing and the health department working together, and then including me and kind of coming up with this. So I'm not aware of anyone who is currently unhappy with the language, although there may be people who are less supportive of the whole concept.
Any other questions for Legislative Council? Thank you.
Thanks, Jen.
Thanks, Jen. Right. So we've done a little bit of introduction, but let's dive into this. Shayla, do you want to come on up? And I'm not sure, is anyone sort of coordinating their testimony with anyone else that we have? Or we're just going sort of right in line?
Sure. So, hi, I'm Shayla Livingston, and I'm a member of the Vermont Birth Center Coalition. I'm really excited to be here. Yes, we have coordinated with Lindsay and Tim Fisher, and so I'm definitely want to defer to Tim too if he has a time constraint. I'm happy to save my words. So first, I just want to really thank this committee for taking this up so quickly. We are very, very excited. The coalition's very excited about this bill. Really appreciate the work that went into it in the Senate. Really appreciate, as Ledge Council said, the attention to detail from the health department and the collaboration from the health department. we are supportive of the bill as passed by the Senate. I was reading your guiding principles, and I feel very confident in saying that this bill supports all of them, and am excited by that. I'm just going to give a little bit of an overview. I do have a couple of beginning answers to some of your more specific questions too that I can speak to. Please interrupt me, Chair, at any point if you'd like me to stop. So first, you heard the definition of a birth center, but just to paint a picture for the committee, and I know I did a little bit of this when you were looking at the CON bill, it is a separate building from a hospital, so it is not in a hospital, and it does not provide the full scope of services of a hospital. And some of the questions you were getting at are really interesting. What we want to do here is provide the same service that is provided by midwives in a different setting. And it's in between a setting that we already have, which is home birth and hospital birth. And the limiting factor is what types of deliveries can be done there. So highly complex cases are not appropriate because they might need additional medical intervention. So in no way does a birth center replace a hospital birthing unit. And in fact, we would always want them to work in coordination with a hospital closely whenever possible. They're meant to feel like homes, and they're meant to feel comfortable. They're meant to have spaces that keep the birthing person relaxed and safe.
I'm going to interrupt you because I think that Woody has a question.
What equipment is available for?
That is an awesome question. I'm going to let Lindsay list that when she goes, because she's a midwife and I am not, and she will give you all of the details. They do have safety and emergency equipment, and they must have safety protocols and transfer plans. I can tell you the statistics, which I think are really important. About 15% of births end up being transferred to a hospital that start out in a birth center. Almost all of those are non-urgent. So what happens is the person who's giving birth gets exhausted, the labor stalls out, they decide they actually do want pain medication, whatever that reason is, and the provider goes with them and transfers them, has a transfer plan, you almost always, I think, in an ambulance to a hospital setting. 2% of cases are urgent. So that's something that's going wrong where they need to transfer the person urgently. So it's a very, very small number. And again, it's very important to have that safety equipment available and have that transfer plan. But this is an incredibly safe setting that is provided in 40 other states in the United States and around the world. So I'll let Lindsay give you the technical details, but that's the big picture.
Ari?
How do those statistics and protocols compare with home birth?
Oh, that's a great question. I don't actually know the answer to that in Vermont, although I wonder if we could find it. I will look into whether we can find that.
Thanks.
Those are national stats. Obviously, we don't have birth centers in Vermont, so I can't give you birth center stats from Vermont. Freestanding birth centers, like I said, they have been recommended by the White House Blueprint for Addressing Maternal Health in the United States. They are supported by the American College of Obstetricians and Gynecologists, known as ACOG, and the American Academy of Pediatrics, as well as the Society for Maternal Fetal Medicine. So this is not considered alternative medicine. I want to be really clear. Birth centers are very standard practice across the U.S. In Vermont, we excel at providing reproductive choice for women and birthing people. That's something that I think we take a lot of pride in. And this is this little gap that we have in reproductive choice. Once you decide to carry pregnancy to term, it is important that people have a role to play in deciding how they receive their care. Again, one of your guiding principles here. And this is a gap that we have. So I think reproductive choice is one of my number one pieces when I talk about this bill and the importance of this bill, especially maybe in this moment in history. Health equity, I am still allowed to say, is a really important part of birth centers, and birth centers really contribute to that because they provide a level of support, education, and wraparound service that ensures improvements in health outcomes, particularly for BIPOC people, LGBTQ folks, a whole variety of people who experience adverse outcomes in other settings at higher rates. The health outcomes themselves across the board are better. Again, this is for low risk pregnancies. So you have much, much lower C-section rates. A birth center C-section rate is about 6% compared to 26% in a hospital setting. And that's comparing similar risk levels, right? You can decrease a preterm and low birth weight babies by about 50%. That is a huge and important indicator in the United States. That is a really big problem that we have here, is really trying to reduce that. When you have a full term and full weight baby, you have way, way fewer health complications for that child, which is of course incredibly important. And it's much less expensive because they do not end up in neonatal care. Access to care. Birth centers provide additional access to care. We know that both pregnant people are leaving Vermont to access this service, and all of our border states, New York, Massachusetts, and New Hampshire, each have birth centers. And so people are having to leave the state to access this care now. And in places where we may see decreases in hospital units, this could be a space where birth centers could help fill a gap. I want to reiterate, and I will say it as many times as you ask me, there is no risk that birth centers pose to hospital birthing units. We need hospital birthing units in Vermont. We cannot have them without them. Nowhere else in the country has this put hospitals out of business, and that is not the goal. It is not a competitive marketplace, or we don't want it to be, rather, I'll say it that way. Talked about safety already and affordability. So when we're looking at trying to decrease the cost of care to both payers, Medicaid and private insurance, but also to pregnant and parenting people, birth centers are much, 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 much more affordable. So they're more affordable just in the standard delivery, but then because of those lower risk factors for C-section, for neonatal care, the cost savings are enormous. We'll give you the back sheet on that, and I will submit my written testimony. But researchers estimate that more than 30 million was saved over 3 years because 15,000 women chose to have their babies in a freestanding birth center. So it's not small. It's pretty big. When you look at the fiscal note, you'll see that Nolan's fiscal note shows that there's no cost to the state to include Medicaid here for freestanding birth centers, and that there probably could be maybe in the future savings. He can't book those savings yet for obvious reasons, but I think that that's a really important point. And again, for the actual parenting individuals, it's a much more affordable option. I want to talk about the questions that you guys brought up. One thing, when you're thinking about what is this and what is this adding to the state, it's not adding services, right? So these midwives are already licensed to do this. These deliveries are already happening either in our border states or here. It's providing a new space for those things to happen. And so when you're talking about, what about pediatric care or lactation services, those are amazing things that can be provided and we would hope would be provided in a birth center setting. Birth centers often have a lot more of those types of supports in place because of the type of care provided. And again, that's some of what contributes to the really good outcomes that you see. The question about inspections. So the health department currently does inspections for hospitals and ambulatory surgical centers. The individuals who would be going out and doing these inspections would have to be trained to the new regulation, but I believe they are almost all at least registered nurses, and they do the inspections already for hospitals. So they have the tech already trained to do birthing units in hospitals. For record review, you should ask the department anyway, but I personally would feel very confident in that team.
It helps. I'm being hyperbolic, but I wouldn't want a plumber going to
Well,
a birthing center.
And it's a really good question because in the past, the question has come up and OPR is in the room, like why aren't hospitals licensed by OPR? Why, aren't ambulatory surgical centers? And, it's a constant debate, but right now, this is where birth centers are normally licensed in the rest of the United States. And some of that is around CMS and having some of that technical training. Not to get into the larger debate because we don't need to. And then I wanted to just talk very briefly about CON. We, of course, the coalition prefers this language because it's very clean and clear. If one day there were an $11 million birth center, wouldn't that be pretty? It is very unlikely. You are about to meet a midwife who is considering opening a birth center here in Vermont. This is a labor of love. We will not probably hit those thresholds. So those monetary thresholds are okay with us, but there are pieces of the bill that you pass that would still require potentially if a birth center was sold, et cetera, et cetera. So we love the cleanliness of this language and the clarity around it. But we're not anticipating birth centers hitting those fiscal limits. And my last thing I'll say is I think that when you're considering, who is going to go to these birth centers and what we are doing in Vermont to expand access to care and provide options for Vermonters, a really big part of it is workforce. You've heard, I'm sure this committee has heard a million times. Our healthcare workforce, right, is shrinking, and it is a problem, and recruitment is an issue. And we know that midwives are not coming here, not working here because they want this option as a place to work and a practice to have. And so we are losing workforce today because we do not have this available. Again, you will hear from someone who's doing that right now. And so when we're thinking about retention, when we're thinking about recruitment, it's not just about the births and deliveries and giving the delivering people choice. It is also about the providers who currently choose to not work here because we don't have this as an option. So I really encourage you all. I appreciate you taking it up so quickly. Encourage you to pass it. And thank you so much for having me.
Daisy, did you have a question?
Thank you for the great testimony and your work on women's health and this specifically. You mentioned that the intent is to have you intend to have a close relationship with hospitals. I'm wondering if your group considered or is considering during the rulemaking process requiring having any particular distance requirements with regard to hospital locations.
Great question. So no, the fast answer is no. And here's the reason why. There will be a requirement for a transfer protocol. There will be a requirement for safety equipment. There will obviously be the inspections to ensure that birth centers are following those protocols and have that in place. Research shows that the number one most important safety provision for women delivering is who is with them while they're delivering. So that person is in the United States trained, we mean licensed, right? So that person is licensed and trained and present. And so when you think about distance, a woman, let's take hemorrhage because that's the scary thing, right? So a woman who is going to hemorrhage at a birth center, if the midwife is there and present with that woman, which at a birth center, the provider is with the woman the whole time in a way that does not happen in a hospital setting because they can't do it. That's not a blame thing. That is not the model in a hospital. They can't do it in a hospital. That's how it's the model in the birth center. So because that midwife is there and is watching the progression of the labor, the risk to the woman is not actually greater than if they're in the hospital and they're alone. And so the distance, when you think about distance, it's not a physical distance. And we know in Vermont that if we tried to make a miles rule, right, that could get really tricky. What if a birth center opened and then a hospital closed? Would you make the birth center close? That could get really tricky. That doesn't make care for those women in that region safer. It makes it less safe. And so it's really, really important that safety is front and center. It's really, really important to have the rules and regulations and the health department involved. But distance alone is too crude a measure and not supported by the science in the rest of the country, which I think is fascinating. And I didn't know that until we took this up.
Super helpful, thank you. And if workforce is, I mean, who is with the woman is really kind of the indicator. I'm curious if, and I know there's a difference between certified midwives and certified nurse midwives. Are you considering making any requirements that a CNM be on staff at all times or present during a birth?
No, so that's another great question, and I think one that comes up. So a certified professional midwife is a licensed provider in maternity care in Vermont. They are required to have the sufficient training around safety. They currently provide home birth services in much more far-flung spaces than one would ever put a birth center in this state today. Those births are safe. Those births are already regulated. And so it does not matter if they are a certified professional midwife known as a CPM or a certified nurse midwife known as a CNM. There are some different things that a CNM can provide that a CPM cannot, but those do not involve emergency care and management of an active delivery. Those are like prescriptions and other sort of peripheral pieces that would follow a woman in a woman's care and could determine what was offered in that birth center. So if it's only CPMs, you might get a different set of services at a birth center than if it's CNMs or if it's an OBGYN and CNMs. And that's why you see some of that language around the permissiveness of what can happen within the licensing scope, so that we are not expanding licensing scope by providing this setting and that those services stay within that space.
Any other questions? Oh, Woody?
Can a birth center advertise itself and its services that are provided?
Yeah, so it's a private, yes, it's a private business, much like a primary care practice, so when you hear, or dentist's office, like, we're accepting new patients at so-and-so dental office. Yeah.
And
Same.
For emergency cases, you mentioned that you have to have the protocol with the local hospital. If you're miles away from a hospital, how do you get that patient to a hospital if the patient needs to be treated further at a hospital?
So again, those protocols have to detail that. What's the transport plan? What's the management plan on site? I'm not a midwife. I'm a public health expert. And so I will defer a little bit of that to Lindsay, but the protocol has to be very clear about how to get there. I do want to be really specific about one thing. It's a protocol that the birth center has to have. It doesn't have to be with a hospital. It has to be, to a hospital. Yeah.
Great.
I got one more.
Oh, yeah.
You've done a little research because you want to do. How many birth centers do you think we need here?
Oh, that's a great question. I love that one. We would be so lucky to get 2. Yeah. Maybe 3. It's, again, this is not a, when you think about an ambulatory surgical center, right? And in Vermont, they can make money, right? That's a business where money is an outcome that is possible. They're doing knee surgeries, they're doing surgeries, and they're doing it more affordably potentially than a hospital, but they are still making money. If you can make a lot of money off a birth center, I'd like to see a business plan because it's going to be rough and it's going to be tight and it's a labor of love and there's not a lot of midwives who are going to be willing to do it. And so if we could recruit and get 1 or 2, it would be so cool.
Thank you, Shayla. Lindsay? Lindsay, welcome.
Good morning. So my name is Lindsay Lachant. I am a certified nurse midwife. I'm an international board certified lactation consultant and a perinatal mental health provider. I want to thank you for allowing me to speak today about the important issue of birth center licensing. I'm in strong support of S18 as it will increase access to Vermont families. I come to you with 20 years of combined experience in maternity nursing and midwifery. Over the past 12 years, I've practiced as a certified nurse midwife in several birth settings, including a large tertiary hospital, community hospitals, and a freestanding birth center located out of state. I currently reside in Southern Vermont, where I was born and raised, but after graduating from midwifery school, I left Vermont to find a midwifery job that matched the philosophy of care that I wanted to provide. That was the birth center model. Since moving back home in 2019, I've had to commute out of state to Massachusetts and New York to work in hospital settings because there's a lack of opportunity in Southern Vermont. I would like to open a birth center. I believe that Vermonters deserve choice in where they give birth and that birth centers provide an evidence-based, affordable, high-quality option that is missing from the healthcare landscape. And Vermonters agree. In 2023, I conducted a market research and community needs assessment of midwifery services, birth center care, and birth options for Vermonters. It was near unanimous support for midwifery care and birth centers in Vermont communities, and 94% of Vermonters responded that they would support the option of a freestanding birth center in their community. I have a professional and personal experience with birth centers. As a midwife, I worked in the only freestanding birth center in Connecticut. It was my dream job. I was able to provide continuity of care, develop intimate relationships with families, support low-risk, healthy people giving birth naturally with minimal intervention. This was the reason that clients came to us and sought out birth center care. I want to also paint a picture of what that practice looked like. In Connecticut, the office space where there were nurse midwives working, seeing GYN patients, seeing prenatal care patients, and we actually took care of patients that chose hospital birth, and we also had hospital privileges. So 60% of the patients in our care wanted to have midwifery care at the hospital. The other 40% chose the out-of-hospital birth center care. We also had a lactation consultant utilize the space downstairs in the office. There was a childbirth education resource room. We had Meet the Doula night. The birth center really became the hub for the community for perinatal care. But that's what people were coming for, that intimate, a different type of care, a different model of care. I had my third baby at the birth center. It was the most satisfying birth because I felt well supported in a safe and welcoming home-like environment. I knew that I was going to get the exact type of care that I wanted without having to ask for it. And being able to go home 4 hours after giving birth and recover in my own bed as a new family with my excited 2- and 5-year-old daughters was so memorable. The midwife came to my house and provided follow-up care the next day. We were so lucky to have increased access to the midwife in the first 6 weeks and extended care. Usually visits last about an hour. In other practices, they're much shorter. Postpartum care that coincides with the birth center model of care includes more frequent postpartum visits. So sometimes you only get 1 2-week visit or a 6-week visit in traditional maternity care. But with the birth center or a home birth practice, usually there's a 24-hour visit, a 3 to 5 day visit to follow up on newborn and breastfeeding. There is a 1 week, 2 week, 4 week, and 6 week visit. So really you're providing a much more expanded, care on both the mom and the baby, because midwives can take care of babies for the first 28 days. There are increased breastfeeding rates, better postpartum experiences, and a positive effect on postpartum mood disorders. I would have loved to have another birth center birth for my 4th baby. I moved back home in 2019 and there was not a birth center available. I would have had to drive 2 hours and 20 minutes to a birth center in New Hampshire. Since there wasn't one within a safe radius for me, I chose to drive 50 minutes out of state to New York to have my baby in a hospital labor and delivery unit. So I was guaranteed 24/7 midwifery access and the option to have a water birth, which is not available in all hospital settings in the state. If there was a birth center here, I would have chosen to give birth there. As we know, the three neighboring states, Massachusetts, New Hampshire, and New York, all have freestanding birth centers. Vermont is one of only 8 states without such a birth center. We know pregnant people would like a birth center and leave the state for care, and also healthcare providers leave the state to work in that model of care. Shayla talked a little bit about like what a birth center is, but a birth center, think about primary care and acute care and the wellness model. And that's what the birth center really is normal, preventative type, like the primary way that we should be taking care of people, and then problems arise. So think about that as I go through that. So there's ample evidence and research that supports the birth center as a community-based wellness model. It encompasses much more than the traditional maternity care system, which is limited in the hospital. It cannot be replicated in the hospital setting. The birth center is low-tech, high-touch care for just a small caseload of clients, similar to the volume of a home birth practice. This keeps the hallmarks of midwifery and the birth center standards in place, aiming for an intimate relationship, respectful care, shared decision-making, and client autonomy to occur. The benefits of this model include improved maternal and infant health, cost savings, improved experience of care, and they align with the Institute of Healthcare Improvement's triple aim, making the option for midwifery and freestanding birth center care integral to improving the current maternity care system. Freestanding birth centers provide equitable care and reduce racial and ethnic disparities. As we know, the healthcare landscape in Vermont is a hot topic of conversation. In S18, we see a confluence that is rarely found, an opportunity to provide more affordable care, better outcomes, and no additional cost to the state, and no service expansion. Health insurance already covers labor and delivery. Birth centers are meant to be more like a home than a medical unit. And this type of healthcare setting would attract people coming back into the state and choosing this type of care who maybe are leaving for this care. Freestanding birth centers are the key to improving maternal health and reforming a broken maternity care system. I urge you to take up and pass S18 as it would expand access to reproductive health care for Vermonters. And I do want to touch on the equipment. This is just a quick run through, or what I came up with. There's normal equipment for like monitoring, vital signs, blood pressures, temperature, sort of the normal care, a Doppler to listen to the baby's heartbeat and pick up any abnormalities. There's comfort equipment that might not be available in a hospital. So massage equipment, a large tub for using for labor hydrotherapy, the option to have a water birth, birthing balls that are good for different positions that you can do in labor for comfort. There's non-emergent equipment, IV fluids. There are medications, hemorrhage medications, if there is a too much bleeding postpartum. Most of these are all listed, specific guidelines set forth by the American Association of Birth Centers. There's national standards that list what makes a birth center safe. And that's what the bill says that would guide the rules and regulation process to make sure that all of these equipment and safety things are available. If, if the newborn needs any kind of transient help with respirations or resuscitation, there's oxygen, there's an ambu bag to give positive pressure to help baby's lungs open up a little bit more. There are airways that you can place to maintain an airway, suction equipment, and then emergency medication like epinephrine. And then for adults, there's also like a cart like you would find at a hospital with maybe an AED or other airways for adults. So, yeah.
And those are the same as would be provided in a home birth.
Well, you can't have most of them, yes, but a home birth midwife wouldn't bring like a crash cart that a hospital
Not a
has
crash
with.
cart, infusion therapy.
Yes,
there's,
IV flare. Yep.
Oxygen.
Yep.
Yeah. That most of what you mentioned.
Yes, most of what I mentioned. Yes.
In a home birth.
Yes.
That's my question that sort of, as we delve into this topic, And we seem to get a lot of statistics on the difference between a hospital birth and a birthing center birth. But in my mind, what we've sort of done to women in Vermont is we've relegated them to only two choices, which is a home birth or a hospital birth. Do we have statistics on the safety outcomes of home birth versus a birth center?
I don't know of a Vermont, like, there's no one organization overseeing home births and collecting data unless it's your individual practice information, unless
I think some data is collected. I mean,
But-
we can get that information for you.
Do we have national data? I mean, as far as, the
So
the safety of all types of settings for birth?
we can get that information. Yeah.
Any questions? Oh, go ahead.
I'm just curious about, and I'm trying, again, to not inject my own personal experience too much, but just the experience of giving birth in a birth center and partly the staffing and just the patient experience of being there. And is there a turnover during the delivery of staff? Who's in the room? You mentioned the equipment and some of the benefits that are available that differ from a hospital setting or some other type of setting. And it made me think of just kind of the setting and why the outcomes are different. And I think that's really compelling. If you could speak to that a little bit, especially the staffing and who's in the room.
I think staffing can look differently based on where the birth center is and what the state regulates. But there should be at least two trained providers who could provide emergency care, neonatal resuscitation, and that they are licensed to care for women in labor. So generally, there would be a midwife, or how it was in Connecticut, because that's my experience, that someone called me and they're in labor. I met them at the birth center. I assessed them. I decided if it was not quite time to be admitted to the birth center, or if it was, then we would go upstairs to the separate facility. Remember, I said the office was downstairs. We would walk up the stairs. The birth center is a locked facility separate from the office, but they are in the same building. We would be admitted into the birth center, and then I would provide all of the labor monitoring and care as the midwife. And then towards the end of the labor, when birth was getting closer, I would call. In Connecticut, we had a registered nurse as our birth assistant, second person at delivery. So that person would come towards the end, and there would be two people present for the birth. And then the midwife does, a little bit of wrap-up care after the birth for a couple of hours. And then the nurse remains with the person for 4 to 6 hours, does all the discharge teaching, cleanup, and then they're discharged.
So the person giving birth isn't separated from someone else giving birth by a shower curtain.
No,
Their birth partner or friend or family member.
they can have anyone they want.
Them.
Yes.
And when they're laboring, do they have privacy with that person to sort of create the environment that helps them through labor?
Yes, definitely. Yes, all of the above.
Yeah.
Yes.
Any other questions? Woody?
How many patients are actually leaving the state for birth centers, other birth centers?
Again, I don't know if we are able to get a very accurate number. The birth certificate data does say that there is a location for Vermont residents where it located other, but it doesn't specify a freestanding birth center. I know that, there are many families that do leave.
Okay. And pricing, I know it's less expensive than a regular hospital. Is that something that'll be online where potential patients can check what it would?
They would have to follow the Transparency Act, that same as hospitals.
Okay.
I was just reading, well, last night a lot about the different birth centers, because I'm not familiar,
Yeah.
I don't have any in here. Some of them do like circumcisions, is that something in your scope?
It's in the scope of a certified nurse midwife if they choose to have that as part of their practice.
Right. Thank
I
you.
just want,
Oh,
can I do
yes, of
one more
course.
wrap up thing on the transfer? Because I think it was somebody's question. The best practice, which around having a transport written policy, hospitals have to accept any patients that come to them because of EMTALA laws. It would be great if the birth center and a hospital had a great working relationship and said, hey, can we, refer to you? Can we talk about the transfer, what would happen and maybe drill with them? But it doesn't have to happen. But the birth center does have to have a written transfer policy. Best practice is around getting your EMS actively involved with creating a transport plan and actually drilling quarterly with your EMS and including them in the process for transport.
Thank you.
Yes.
Helpful.
Thank you so much.
We have Carolyn. Oh, yes. Do you mind, Carolyn, if we switch to Dr. Fisher?
Not at all. Please go ahead.
Okay.
I'm waiting in the
Thank you.
wings.
Dr. Fisher, thank you.
Hi, everyone. Can you see and hear me okay?
And I apologize, we're running a little
Great.
behind.
No problem. It's actually, I've really enjoyed listening to the conversation and have wanted to jump in and answer some questions because they're good ones and are ones that I've thought a lot about in my work. So again, thank you. It's nice to see some familiar faces on the screen. I'm sorry I can't be with you in person. I've submitted a written version of my testimony as well. I'm probably going to cherry pick from that a little bit in the interest of time. And I'd like to not read my whole CV to you, but by way of background, I'm an obstetrician gynecologist. I practiced in Northern New England for 18 years, first in Keene, New Hampshire for about 10 years, where we had a birth center in Swansea, New Hampshire, about 10 miles south of us. And then at Dartmouth Hitchcock in Lebanon for another 8 years. And I was deeply involved in working with those facilities and those practitioners, largely around some of these issues that you've brought up about risk, about transfer, about collaboration, those are all really, really important things to think about as you move forward. I'd be happy to share more information about that. I also was really privileged to be the medical director of an organization called NEPQUIN, the Northern New England Perinatal Quality Improvement Network, which represents all the birthing facilities in both New Hampshire and Vermont. So I got to know the community well. And finally, much of my academic work at Dartmouth was really around the issue of labor and delivery unit closures in Northern New England. And for various reasons, New Hampshire has been a little bit harder hit by that. As far as I know, still only Springfield Hospital in Vermont has needed to close their labor and delivery unit. But this is the big crisis. This is a big problem in rural communities and an interesting intersection of the conversation that you're having about birth centers. So I unfortunately and fortunately moved just south. So I'm coming to you down 91 from Northampton, Massachusetts. There's been a lot of activity in Massachusetts over the last couple of years, and including recent passage of a bill called an Act Promoting and Enhancing the Sustainability of Birth Centers and the Midwifery Workforce. So suffice it to say, this is a timely and important issue kind of across the region. I wanted to just highlight some data and some other information, some of which has already been alluded to by Shayla and Lindsay. But here we go. So, thinking about site of care and location of birth. Again, closure of over a third of hospital-based labor and delivery units in New Hampshire and Springfield Hospital's closure really only served to reinforce the urgent need for development of alternative sites for both ambulatory care as well as labor and delivery services of risk-appropriate patients. As an obstetrician gynecologist, my colleagues and I work in hospital-based labor and delivery units, and we're caring for an increasingly complex patient population who require a level of resources that are really not necessary for most healthy people experiencing physiologic labor and pregnancy, labor, and delivery. And what we know is that when we place those low-risk patients in a high acuity and resource-intensive environment, we expose them often to unnecessary interventions that ultimately result in poorer outcomes, despite our best intentions, including higher rates of cesarean delivery, perinatal trauma, and others. Far from being competitors, birth centers and hospital-based units really can improve health outcomes as collaborative, complementary models and sites of care. To quote my professional organization, ACOG, accredited birth centers provide needed obstetric care for most women who are giving birth in the United States. Furthermore, they often provide maternity care in rural and underserved communities, which offers the benefit of keeping women with low or moderate risk pregnancies in their local communities. Accredited birth centers are an integral part of many regionalized care systems. You may hear arguments about increased risks of delivering in birth centers, and they're just not supported by high quality evidence. And really, to the contrary, midwifery-led care in birth centers has been identified as a potential solution to improving maternal outcomes and lowering costs of care in the United States. Some of you may be familiar with a big study that came out of the Center for Medicare and Medicaid Services and published in 2018. It was called Strong Start. And it showed that women who received prenatal care in Strong Start birthing centers had better birth outcomes and lower costs relative to similar Medicaid beneficiaries not enrolled in Strong Start. Rates of preterm birth, low birth weight, and cesarean section were lower among birth center participants, and costs were more than $2,000 lower per mother-infant pair during birth and the first year postpartum. These promising birth center results may be useful to state Medicaid programs seeking to improve the health and outcomes of their covered populations, and not just obviously for patients covered by Medicaid. So, I think as a public health intervention and a means of responsible stewardship for precious healthcare resources, this legislation would go a long way toward moving that ball forward. You've addressed a little bit, I think, the CON issues around birth centers, and I think not having a CON process is really important for the success of establishing birth centers in Vermont. I'll close my formal, testimony there. I'd be really interested in your questions and the dialogue.
Any questions for Dr. Fisher? I think you make a very compelling case. I'm convinced. Yeah. Is there anything, I don't know if you've had a chance to read through this bill at all. Is there anything that you think, you talked about how having a collaborative relationship, between hospitals and birth centers and nurse midwives and obstetricians. Is there anything in this bill that you think we could strengthen that collaborative relationship, or is that something you don't think would be necessary?
I think you have a careful line to walk, right? And leaving things a little bit more vague is probably better than having too much specificity. I think at the end of the day, again, my personal experience as a clinician, as well as my sort of academic work around this issue, would suggest that close relationships between those professionals who are going to share patients and clients is really important. I could give you some examples of some of the things that we did in New Hampshire. We started by having, we had a potluck dinner one night, and we invited all the OBGYNs, all the CNMs, the licensed midwives at the birth center, and representatives of the local EMS crews, EMS agencies. And we just sat down and we just brainstormed, and we just talked about, what are some potential pain points? What are things that are frightening to people? How can we put in place, some drills? How can we simulate some of the things that we might see? Some of your questions about, well, what equipment is in a birth center? What can you do and what can you not do? Providing a forum for people to sort of share those thoughts and share that information really goes a long way in easing anxieties. And again, this model of care is well established in other states and in most other industrialized countries, mostly in Western Europe, where this is just how it works. And making sure that we eliminate barriers in those transitions of care is really, really important. So while it's true that, a hospital doesn't have to have a policy or procedure in place, it sure behooves them to do so and to work with the community-based midwives and EMS professionals. At the end of the day, we all want the same thing, right? We want safe and healthy outcomes for pregnant people and their babies. So everyone has a important vested interest in making sure that goes well.
Thank you. Any questions for Dr.
Doctor, thanks for being in order for us to get this thing right, is there one thing in particular that we should have in mind in a rural state like Vermont? Forget about the Burlington corridor. Let's talk about the rest of the state. What is something that we should make sure we get right?
Yeah, it's a great question. Again, I think Lindsay could probably speak better to the specifics. My understanding, there is a national accrediting agency for birth centers called the AABC. Those accreditation requirements are incredibly detailed in, all of those who, what, where, when, et cetera. I think ensuring that there are requirements around risk assessment of patients who are appropriate for midwifery and birth center care is important. And you have most of those, and I'm familiar with Vermont's regulations around home birth. You have most of those in place already. So carrying those over, again, making sure that patients, clients who are seeking care in a birth center are appropriately risk stratified, because there are going to be some people who really want to have their baby in a birth center, and I know Lindsay could speak to this, who are just not good candidates. And my experience working with midwives over the years is that puts the midwife in a really uncomfortable position sometimes, because they know, whether it's because someone has underlying diabetes or high blood pressure, et cetera. So I think there have to be strong regulatory, provisions in place to make sure that the right kinds of patients are seeking and receiving care.
Thank you very much.
Thank you. Any other questions for Dr. Fisher? Okay. Thank you so much for taking the time to be with us today.
Well. Very welcome. Thanks.
And Carolyn, welcome, and thank you for rearranging a little bit. We appreciate your time as well.
Thank you so much. Thank you all for the opportunity to testify as a consumer today. My name's Carolyn Barnwell, and I've lived in Vermont for 11 years, but I crossed over to be able to give birth in a birth center in New Hampshire. When I became pregnant, I took an online course that's popular called Empowered Birth, and it lays out 3 options for American women: birthing at a hospital, a freestanding birth center, or at home. And I didn't know about birth centers before this course, but they seem to be this perfect happy medium, and I was so excited. I started researching immediately, but I couldn't find one because there isn't a single one in Vermont. And I really felt that where and how to give birth was one of the most personal, multifaceted decisions I'd ever made in my life. I felt like the risk of a home birth while not living near a hospital was too high for me to relax. And the thought of having a baby in a hospital made me uncomfortable, because at the time it was the height of the pandemic. And I also just believe, like, pregnancy is not a sickness. I don't want to be in that environment around people who are sick, germs, beeping, lots of staff turnover. It just made me feel really tense and anxious thinking about that. And so I thought, I've got to find a birth center. I want to have that calmer experience. I want a more individualized experience. And then my husband was totally on board after we researched the data on birth centers, and we learned there's actually less risk in birthing at an accredited birth center, better outcomes for moms and babies. And that was true all the time, not just during a pandemic. So we were sold, and we had no doubts in finding our birth center in New Hampshire. So I knew if I was to remain a low risk pregnancy and remain eligible to have an out of hospital birth, the most important thing was for me to get that personalized care and to feel safe and respected, and that feeling would increase my chances of having an uncomplicated, unmedicated vaginal birth. And my care during pregnancy at the birth center was so good that I was honestly excited to give birth and be in my own private room with a king-size bed throughout my pregnancy. I had hour-long appointments with super experienced midwives, and they helped me make really informed choices. They even sent me home with a book that they had compiled with all the latest research on everything from what to eat to help with nausea to the vitamin K shot offered to a newborn. So like I really knew why I was deciding every step of the way. And then the birth center overall was a very relaxing place to be, and it was a welcoming environment. They had a little library. It was honestly world class. And I remember thinking so many times, this is it. This is an option that I wish every woman had for their healthcare. So I did do all the paperwork and register at the nearest hospital in case I needed to transfer. I understood that it wasn't a guarantee that I would be able to actually give birth in the birth center, even though I had all of my prenatal care there. But I'm happy to share that I had a very swift, normal, unmedicated birth. It was everything that I hoped for. Our baby was born in this big tub with my husband in there with me, and it was just one of the most empowered, intense, and beautiful experiences of my life. I'm so grateful for it. I still have tears come out of my eyes whenever I really think about it and share how amazing my birth center birth was. And the three of us were able to go right from that tub into that king-size bed and just snuggle together as a family, learn how to breastfeed, and be fed a warm meal. And then the postpartum care and the next few days while I was in my own home was just beyond what most mothers ever get. Rather than one postpartum appointment at 6 weeks, I had multiple home visits and appointments, as well as unlimited tech support from the midwives, just underlining that this is not a money-making business model, clearly like a labor of love from the midwives. So while a birth center birth isn't for everyone, it was absolutely the right choice for me and my family. And I was so happy that I was able to go over to New Hampshire to do it and have the exact experience that I hope to have. Vermont families really deserve to have this choice for quality and cost-effective care. It is proven, as Shayla shared, the health outcomes are better. And really, in conclusion, I want to say that pregnancy and birth is so personal. And it's so important to feel cared for and safe on a nervous system level, right? Because that will help your outcome. And I knew that the place that I would feel the most cared for and safe and relaxed was a birth center. I hope that you will help us make this choice available for women in Vermont. Thank you so much.
Thank you, Carolyn.
Thank you so much.
Thank you. I'm not sure I know where you're located. How far did you have to drive to get to?
I drove 40 minutes. I live right in between Bridgewater and Woodstock. And so
Okay.
I drove over to Hanover, New Hampshire.
I'm looking at your pictures that you submitted. It looks lovely.
Amazing, right? It's amazing.
Jeez, that's a lot nicer than I had.
I know. I was like, this is kind of like a European hotel room. It's like nice and
Yeah, I just got to further that question of 40 minutes. How many trips did you have to make before the birth and after they came to you? So approximately, because the reason I'm asking, I live on the Canadian border on the other end. If we have a birth center somewhere, transportation is going to be an issue.
I honestly can't remember. I feel like maybe Lindsay could speak to this better. Maybe like I was going there every couple weeks while I was pregnant. And then after giving birth, I feel like I only went back twice, maybe. Does that sound
Thank
right,
you.
Lindsay?
Yeah.
Mhm.
So depends where it's located here. Somebody said they mean like two.
Any other questions?
Y'all are just making me wanna have another birth, but there's
Okay.
some medical advancements.
I can say, every time we have this discussion, I have to think back about my own birth, but I never, ever say, it makes me want to have another.
That's the reason why you have babies when you're young.
Carol, thank you so much, and thanks for sharing your family's experience with us.
Thank you.
Congratulations. Oh, how long ago was this? Like,
2 years.
My
Years.
daughter is turning 4 in a month.
oh,
Yeah.
All right. Yeah.
Been a long time, but.
thank you. Thank you for so much for joining us. I think we are done for the day. We can go